Chris, are you talking to us? Your microphone's off.
Okay, let's try that again. Thank you for joining us for this morning's heart failure in palliative care and heart failure talk. This is part of our PY2 webinar series. Now we have...
Did you know you can contact VA Hudson Valley Healthcare System toll-free?
All right, the new year is getting off to a good start.
Good, I was actually about to call you. Yeah, so did he finally, because I'm just now getting to finish up my notes.
Okay, let's try this again. So we're glad that you are joining us for this morning's webinar, Palliative Care and Heart Failure. We're pleased to have joining us Dr. Mandy Daniels, who's a PGY2 in pain and palliative care at the Hospice of Southern Illinois. As a reminder, this webinar is being recorded and will be available for future viewing on the homepage of the Society of Palliative Care Pharmacists website. So with that, I'll introduce Dr. Daniels, and thank you again for joining us.
Thank you for that introduction, Dr. Herndon. As he said, I'm with Hospice of Southern Illinois, and I hope everyone had happy holidays, happy new year, and thank you for joining. So this topic this morning came about from a journal article that was just published probably about a few months ago. That was a palliative care and heart failure trial. So I really wanted to talk about that, so hence this presentation. So to get started, if my mouse would work, there's our objectives. So to identify the mechanism for developing refractory heart failure, differentiating between the heart failure classifications, and then selecting appropriate treatment for each end-of-life symptom. So for your heart failure in general, there at the bottom, you can see that 5.7 million Americans over the age of 20 have heart failure. It's estimated that about 5 to 10% of those are stage D, but the stage D prevalence is hard to determine, secondary to many patients really dying before they can even get diagnosed with this stage D. So from all hospice admittance, cardiac and circulatory diagnoses account for 19.3% of that primary diagnosis when you're admitted to hospice. And then another thing to keep in mind throughout this presentation is that acute decompensated heart failure is the most common cause of hospitalization in that Medicare population. So for those of you that aren't super familiar with hospice, most of our patients are Medicare pay. So not a lot of private insurances and things like that at this point in time. So the pathophysiology of this, what we call refractory heart failure, is the maladaptive remodeling, which we know happens in your heart failure. Well, this is just causing that recurrent damage to that myocardium, which just keeps presenting with worsening symptoms. So at this point, we're at about the top structural damage that we can give to that heart, which is really just an endless circle of worsening symptoms and then worsening that damage. So to predict your prognosis with heart failure, there's a couple tools that are out there, but the most one that the literature uses to kind of predict this prognosis is the Seattle heart failure model. So this is an algorithm for heart failure with reduced ejection fraction. And just to clarify, everything that I go over today will be, of course, about heart failure with reduced ejection fraction. So this Seattle heart failure model predicts a 1, 2, and 5-year prognosis. It calculates a baseline prognosis and then an intervention prognosis. So this baseline prognosis is, for lack of a better words, no intervention. So whether we don't change anything and we keep going the way that we're going, that's going to be your baseline prognosis. And then your intervention prognosis is calculated based off of the demographics, what medications you're on, what dose of diuretics you're on, and then certain pertinent lab data, and then whether or not there is a device present. So you get 2 calculations for this calculator, which this is an example of the Seattle heart failure model calculator. So you can see at the top there that it's broken down by baseline and intervention prognosis. So then you can see the 1, 2, and 5-year divisions, and then they're broken down by survival and mortality, and then mean life expectancy. So you can see that for the baseline heart failure calculation for this patient. So right now we have a 65-year-old man who is a New York Heart Association Class 3A with an ejection fraction of 30% and a blood pressure, systolic blood pressure of 120. So and 80 milligrams of furosemide. So you can see that just that information right there is already a lot better of information, or a lot healthier of information than a lot of the patients that you will see either being admitted to the hospital or being admitted to hospice. So this already can give you an idea of how, the survival and mortality data for patients that are worse off than this. So going back up to the top, you can see that this baseline calculator provided a 5-year survival baseline for this patient of 31%. Now, that's not very high. So a 69% mortality. On the intervention calculator, you can see that the survival went up to 66% at 5 years, and then the mortality went down to 34% at 5 years. And that's based on the interventions at the bottom of the calculator. So we know this patient was on Lasix. All right, well, let's go put them on this ACE inhibitor, a beta blocker, and an aldosterone blocker. Those are the interventions that we're doing. So that is what's increasing that 5-year survival percentage. And then this patient has no device checked. So if that device is checked, we can all assume that that survival might change a little bit. So that's the Seattle heart failure model. The reason that the literature per se is advocating for this is because predicting that outcome for those patients with stage D heart failure is so challenging. One survey even showed that physicians thought that they could predict 6-month mortality most of the time or always in only 16% of their heart failure patients. And then on the flip side, patients also have been extremely poor at predicting their own survival. So in a study using this Seattle heart failure model, to estimate life expectancy, patients with chronic stable heart failure estimated a survival basically consistent with the data for individuals that don't have heart failure. So they thought that they were living or going to live just as long as these patients without heart failure, which was about 3 years longer than what this calculator was predicting in most of those circumstances. So very poor insight a lot of the time from both physicians and patients about how this heart failure is really impacting their life. So things that we can see at end-of-life heart failure include dyspnea, pain. Pain is kind of interesting because pain's not typically experienced throughout the heart failure course until you actually get to this end stage or refractory heart failure. Of course, weakness and fatigue, nausea, anorexia, constipation, edema, which is, I think, a no-brainer, and then cough, altered mental status, anxiety and depression, sleep disorders, and the biggest that we focus on for our patients admitted to hospice services is that decreased quality of life. So for the first symptom, which is dyspnea, main cause is your hypovolemia. And so treatment for that would be the maintenance of the euvolemia. So diuretics, sodium restriction, and fluid restriction. And I will give the forewarning that a lot of the treatment options that are listed on these slides are not what we always do for our patients that are admitted to hospice. This is just what the literature suggests as treatment options. So again, it might be a little bit different because we are, at the end of life, if you will, and we're on hospice at this point by the time that we see these patients. So a lot of these things, would be kind of cruel to do to our patients on hospice. So just to keep that in mind, but these are always our options. So getting back to if it's systolic heart failure, of course, your ACE inhibitors or ARBs, your mineralocorticoid antagonist, digoxin, and then plus or minus inotropic infusions. So you'll hear a lot of differing opinions sometimes on the ethical dilemmas that present themselves when these types of things come up. So the digoxin is appropriate in patients with this dyspnea, like that persist basically despite the diuretics, and if you choose to do that sodium restriction and that fluid restriction. And then the IV inotropes may provide some palliation of symptoms and improve quality of life, but of course this would require a lot of discussion with that patient and family about both increased risk for arrhythmias and mortality, which we have data for already. So other option is your opioids. Now the thing to be mindful about with opioids is that a lot of these patients are going to have some sort of, chronic kidney disease or something. So renal dosing and building up of those metabolites of those opioids is something to always watch for. So fentanyl and methadone in those cases, if that provider is comfortable with those, can be good choices if there's some renal dysfunction. And then oxygen is appropriate for these patients if they're hypoxemic. So that's something that most of our patients will have oxygen anyway. Quite truthfully, most of our patients that get admitted for heart failure also have another diagnosis of end-stage COPD. So there's a lot of overlap in that treatment. So oxygen is usually available anyways, so that can help with this if they're hypoxemic. Something I didn't put on the slide but can be considered are benzodiazepines, and that's if there is anxiety that's related to this dyspnea. So that can help patients as well. And then right now, at this point in time, there are no recommendations for any dietary supplements, relaxation techniques, or thermal therapy. So these actually have just unproven benefit right now. So our next symptom is our pain. So causes, you can take a guess at what causes pain at this point in time. There's definitely a lot of things going on. So treatment for this is first step treating that underlying cause. So is it ischemic chest pain? We do or can continue those anti-anginal agents for these patients. Typically first line will be our opioids. And then NSAIDs, literature says to generally avoid them because of their effects on renal function, the sodium and fluid retention, and GI side effects. But I can tell you, if a patient's telling me that, they're getting by on 2 Aleve per day, I'm not going to probably change that just because it's an NSAID. So it's constantly, patient-specific scenarios. So for our fatigue and weakness, definitely multifactorial when it comes to causes. So we can have cardiac insufficiency, the loss of the muscle mass that is just the aging process, the deconditioning, and other comorbid conditions that these patients can present with that would contribute to the fatigue and weakness, such as anemia, thyroid dysfunction, sleep disorders, and depression. So this is one of those treatments that kind of stopped me in my tracks when I was, reviewing all the literature, and they recommend exercise, which sounds great on paper. But for the majority of patients with end-of-life heart failure, I don't think that they're going to be able to exercise to the degree that would help them, get a little stronger. So something you can consider are those stimulants to help this fatigue and weakness. And you'll see later that they can also help with that acute depression as well. So next we have our GI disorders. So our first one would be that cardiac cachexia, and it's caused by an increased catabolism plus anorexia. So anorexia is something, again, for those that don't have a lot of experience seeing end-of-life patients, anorexia is something that comes often with those patients. So that's not really surprising by any means. So the treatment is suggested to optimize that ACE inhibitor and carvedilol. Now, things to be mindful with that treatment recommendation, again, always patient-specific, but a lot of the times we'll see that our blood pressure is dropping at the end of life, and we're having to decrease the doses on some of these medications. So it's not always going, of course, with any medical scenario, it's not always going to work out the way that an ideal situation would. So there can be some appetite promoting agents that can be prescribed. So Megace is one. So mindful that this can promote fluid retention and no clear benefit in heart failure. Now, I think this is interesting again because this brings up another ethical debate with your end-of-life care of patients. The wanting to eat is decreased quite naturally when you reach the end of life. And so some would view giving appetite-promoting agents as an ethical dilemma or considered, we're trying to treat this patient, it could be considered aggressive treatment, which again, I think there's a lot of ethical dilemmas and a lot of these treatment options that we're going to go over today. So just being mindful of what setting you're in. So if you're in a hospice setting, it might differ. If you're just, palliating these patients, then that will differ. So again, just things to keep in mind throughout the presentation. And then nausea. So reduced intestinal perfusion and medication side effects, of course, are contributing to this. Treatment most often we'll give ondansetron or your Zofran, and then sometimes adding on or replacing that Zofran with that prochlorperazine or your compazine. Constipation, as we know, presents itself a lot in end of life. So this is caused by either decreased food intake, physical inactivity, or medication side effects. So again, your treatment suggested to try high fiber foods. Again, if your patient's not eating, then that might not be the best option. So laxatives, are your next go-to. Now, I can tell you that for hospices specifically, per the CMS measures, a laxative is required to be on a patient's profile and available if there's an opioid present. So if you're using an opioid for, let's see, either the dyspnea, the pain, or even for another disease state management, there should be a laxative available on that profile. So next are our depression and anxiety. So this was surprising to me that depression was found in 30 to 35% of patients with advanced heart failure. So the causes, I think, for both this and anxiety, you can kind of assume that while we're at this end of life stage, this is happening. Of course, you might be a little either depressed or anxious about it. So treatment, they recommend the CBT, so your cognitive behavioral therapy, spiritual support, or medications, which can be either an SSRI, a TCA, or another stimulant. So your SSRIs are usually your first-line options, but of course being careful for fluid retention, possible hyponatremia, and QTc prolongation. So especially that fluid retention is something that in a heart failure patient, of course, that we are worried about that. So your TCAs, specifically your secondary amines, are what the literature recommends, so your nortriptyline and acipramine, but again, being careful for that QTc prolongation. And for your stimulants, methylphenidate is what we use sometimes if we have a patient presenting with new onset, depression due to, either their hospice admittance, they're not ready to die, things like that can definitely make a patient depressed and or anxious. And so we will use methylphenidate for a while to help make that person feel better, if you will. Because the thing that we know, of course, about our antidepressants is that, they will take a while to work. They are not the overnight cure for depression. So really making sure that you're focusing on that quality of life of the patient. So anxiety, again, kind of already talked about the causes. The treatment, they recommend support groups, heart failure education, and short-acting benzodiazepines, so a lorazepam. I can tell you, I think 95% of you guys could look at those three and select which one is most often used. That would be the lorazepam. So just being mindful again of, what is this patient going to want? Do we really want to provide them heart failure education at this point in time? When they're at end of life, yes, but that doesn't mean I'm going to withhold, treatment for them. Okay, so moving on to sleep disorders, this one really took me by surprise. 50% of patients with heart failure will have some sort of sleep disorder. So sleep disordered breathing, which is caused by either that central sleep apnea or that obstructive sleep apnea. So treatment with that, or for that, excuse me, is either your CPAP or nocturnal oxygen. I can tell you that we use nocturnal oxygen a lot. CPAPs do have the ability to cause anxiety in a lot of our patients. So that's not something that, unless they came in on a CPAP, probably something that you're not going to start. Because of course, sleep studies and everything that goes into getting a CPAP machine, probably not the best option. So I can tell you that we use nocturnal oxygen a lot to help these patients with that apnea. So insomnia, again, multifactorial cause. It can be either the orthopnea from the heart failure, nocturia. It can be because of the sleep disordered breathing, so your apnea, and then also anxiety and depression contribute to that insomnia as well. So the treatment, first step is to treat that underlying cause, which I think most people, do think of when it comes to sleep disorders. Sleep hygiene, and then medications. So you can use either your trazodone or your zolpidem. So for confusion and delirium, which I think we can all guess that, yes, it's very, very common for our end-of-life patients. Causes impaired cerebral blood flow, repetitive microemboli, and then, of course, your medications. So your opioids and benzodiazepines we know can contribute to these things. So for treatment, either reducing that dose or eliminating that medication that's causing this, regulating the environment, and then if agitation or combativeness is present, small doses of haloperidol can be considered. However, I can tell you that a lot of, depending on where the patient is located, a lot of your long-term care facilities, at least around our area, will not allow PRN antipsychotics. So this would be a huge barrier for our area, not necessarily all over, but definitely for us. So for the cough, it can be caused by either pulmonary congestion, your ACE inhibitors, of course, aspiration pneumonia, or bronchitis. So treating this, of course, we're going to diurese these patients. You can switch to an ARB, although this is not the most common reason for cough at this point in time. You can give a cough suppressant such as dextromethorphan, or your opioids can also help with cough. So things that we do, sometimes we will give a little hyoscyamine or Levsin to help with a cough if it is like a wet productive cough. So if it's something that they just can't cough up themselves because they lack the strength or the ability to cough that up, we will give some Levsin just to try it out just a little bit to help them, symptom-wise. So our last one is the edema, so obviously caused by fluid retention. So we're going to treat that underlying cause, which sometimes can be your nocturnal hypoxia. So we can either aggressively diurese these patients, we can optimize their other heart failure medications, we can elevate their legs, and then we can place them on fluid and sodium restriction. A lot of these, in my situation, again, at hospice, we're just going to increase their dose of their diuretic and elevate the legs. Again, optimizing other heart failure medications sounds great. However, like I said, our patients are starting to become more hypotensive and we're having to decrease these medications. So optimizing those medications is not always going to work for us. So now for kind of the bread and butter of this presentation is the quality of life, the decreased quality of life symptom that patients will present with. So this study was the palliative care in heart failure trial, and it randomized 150 patients with advanced heart failure to either usual care or usual care plus a multidimensional palliative care intervention. So this whole trial was conducted basically to assess the impact of that interdisciplinary palliative care intervention combined with that usual heart failure management. And we're looking at the heart failure related and overall quality of life in these patients with advanced heart failure. So that usual care is defined as being managed by a cardiologist-directed team with that heart failure expertise. So basically what you would think of for usual care for a heart failure patient. The usual care plus that palliative care focused on a palliative care team basically in cohort with the heart failure or cardiology team. And they looked at managing the physical symptoms, any psychosocial or spiritual concerns, and also advanced care planning. And then the nurse practitioner, that was their palliative care nurse practitioner, also continued to follow these patients for their palliative care needs after discharge in the outpatient setting. So it's a continuity of care here. So the primary endpoints that this trial looked at, your first one was your heart failure specific quality of life using the Kansas City Cardiomyopathy Questionnaire, which is a 23-item questionnaire, disease specific to heart failure, scored from 0 to 100. And then the second tool that they used was the general and palliative care specific health-related quality of life using the Functional Assessment of Chronic Illness Therapy Palliative Care Scale. So this is the FACIT-PAL scale. And this is a 46-item measure of self-reported generic quality of life from 0 to 184. Now for both of these tools that they used, the higher the score, the better. So for that Kansas City questionnaire, the higher score represents just a better health status. And then for that FACIT-PAL scoring tool, a higher score is a better self-reported or perceived quality of life. So what they found with this, so your usual care alone, plus your usual care plus palliative care, you can see the graphs there. So that Kansas City Cardiomyopathy Questionnaire is there on the left, and then that FACIT-PAL is on the right. Your blue line is the usual care plus palliative care. Orange line is your usual care. So you can see that pretty close to starting out maybe week 2, maybe up to week 6, but then you see definitely by week 24 an increase in those scores for that usual care plus palliative care. And both of those were statistically significant. The secondary endpoints that this trial looked at were the scoring on the FACIT Spiritual Well-Being Scale, which is similar to that FACIT-PAL score, but this is a 12-item scale really assessing the role of faith in illness and meaning, peace, and purpose in life, and that's scored from 0 to 48. And then the scoring on the Hospital Anxiety and Depression, or the HADS scale, and that's a 14-item scale divided into subscales of depression and anxiety separately, scored from 0 to 42. So what they found for that FACIT spiritual score is, again, the higher the score for this one, the better. So you can see that that blue line going back to that usual care plus palliative care was higher pretty much continuously from just that usual care alone group. And that was statistically significant as well. And then for your HADS scores, the lower the score, the better. So this one flips. So you can see the depression scores on your left and the anxiety scores on your right. And you can also see, again, that that usual care plus palliative care group consistently was better or scored better on the depression and anxiety screening or scales, I should say, rather than that usual care alone. So basically what we learned from this palliative care and heart failure trial is that we need to be incorporating palliative care into into this treatment, if you will, when it's necessary. So of course that's a decision always to be had with the patient and the family and whoever else wants involved. But what we're finding a lot of the times is not even just in heart failure specifically, but across the board with patients, is that we're not introducing palliative care soon enough. So patients are missing out on the benefits that palliative care can offer. So I think education is a big point, especially that we can help provide to patients. And then taking that a step further, hospice admittance as well. So of course there's multiple conspiracies about what hospices do and what they don't do, etc. So education again. So really this trial, if anything, is telling us to get involved sooner, to go explain to patients the benefits that palliative care can have on both, your anxiety, your depression, your spiritual needs, anything like that. So I think this trial was very helpful in showing us what we can do to help. So with that, there's my references, and I would be happy to take any questions.
Mandy, great presentation. I really appreciate you taking time to do such a thorough job. As a reminder to everyone, if you would like to ask any questions or chime in, please unmute yourself or feel free to use the chat function at the bottom of your screen.
Amanda?
Yes.
Yeah, this is James Ray. I wanted to ask you, have you used any ketamine for depression in these patients?
We have not. We actually don't use ketamine in our hospice setting. Not to say that there's any reason for it. I think it's probably a comfort level, for where I'm at on using ketamine. So I think that probably plays a role. But no, we have not used any ketamine.
Okay, thank you.
Mandy, did you see any data regarding inotrope use in heart failure and specifically the hospice patient?
So not specifically to hospice. I mean, most of the data I found was, just specific to palliative care. So I interpret that as hospice sometimes, depending. But as I was kind of saying, which I can touch on more, I think it's one of those ethical things because a lot of people would view that as, we're not going to go give them an infusion. We're trying to increase their quality of life, not, stick them to give them some medication. So although it can palliate some symptoms, it does increase the mortality as well. So I think that that's one of those things that everybody has to be on board with. So I know the palliation data is there, but we also know that the mortality data is there. So
Are there any other questions? Okay, well, thank you very much for taking time on what I know is a very busy Friday morning for all of you. Again, thanks to our speaker, Dr. Daniels, for a phenomenal presentation. As a quick reminder, this webinar and all the other PGY2 pain and palliative care webinars are freely available on the homepage of the Society of Palliative Care Pharmacists. Thanks again, and I hope everyone has a great weekend.